whatever. All right, so today we're going to discuss, begin our section on airspace disease. So we start with alveolar consolidations, and basically the question here is, what can the lungs be filled with that would give you airspace disease or consolidation? So what are some of those substances that the lungs can be filled with? Get close to the microphone.
Proteinaceous material.
Well, you're not going to start with that, are you?
Edema, like fluid.
Right, close to the microphone, please.
So like fluid.
Yeah, so fluid, and what do we call that? You said pulmonary edema. What else can alveoli be filled with?
Blood products. Like
Okay, again, that you're not going to put that at the top.
Right.
So what would come after fluid and pulmonary edema? What's the next most common thing? Well, you read X-rays on pneumonias every day, right? So that would be what?
Like pus.
Pus. So pulmonary edema is the most common. If the air spaces are filled with pus, we call that pneumonia. With blood, we call it pulmonary hemorrhage. Air spaces can also be filled with cells. That can give you airspace disease. So can anybody tell me out there what kind of diseases would give you airspace disease with cells filling the alveolar spaces? What might do that?
Like tumor?
What kind of tumor?
Like adenocarcinoma?
Well, yeah, so well-differentiated adenocarcinoma used to be called bronchoalveolar carcinoma. There's another type of tumor also that can give you airspace disease and air bronchograms because of an infiltrative pattern of growth. It's pretty rare in the lung. What is it? That would be lymphoma. And you also mentioned protein, pulmonary alveolar proteinosis, but that is way down on the list. So if I show you this chest radiograph on admission, okay, so the lungs look pretty clear, and then 6 hours later, the lungs look like this. So the findings 6 hours later are?
Diffuse opacities throughout the...
Yeah, so we have diffuse bilateral airspace disease. What could that represent?
Pulmonary edema.
Right, so pulmonary edema. And when we're talking about pulmonary edema, how do we discuss pulmonary edema?
In terms of distribution?
Well, no, when we discuss pulmonary edema, there are two basic categories of pulmonary edema, right? What are those two categories?
Cardiogenic and non-cardiogenic.
Yeah, right, so cardiogenic versus non-cardiogenic pulmonary edema. So which would you favor here?
Cardiogenic.
Why would you favor cardiogenic pulmonary edema?
Actually, non-cardiogenic because the heart isn't.
Yeah, so the
heart's
heart's normal in size, right? So there you might favor non-cardiogenic pulmonary edema. And some of the most common causes of non-cardiogenic pulmonary edema would be what? What are some common causes of non-cardiogenic pulmonary edema? The rest of you can help. Non-cardiogenic pulmonary edema, name some causes.
Drowning.
Near drowning, right? Neurogenic pulmonary, you're picking some rare things. I mean, a very common thing we find in the hospital day after day. Yeah, ARDS, sure. ARDS is a very common cause of non-cardiogenic pulmonary edema. This patient also has a Swan-Ganz catheter, so if somebody develops pulmonary edema and they have a central line, you might also consider what? Aggressive overhydration or fluid overload, okay? We can turn out the lights. All right, so we can have cardiogenic pulmonary edema, non-cardiogenic pulmonary edema. There are many causes of non-cardiogenic pulmonary edema. And then we'll also talk about asymmetric pulmonary edema. In medicine, they go through these various categories of pulmonary edema, which can be quite complicated, but in radiology, we like to simplify things. So we can have cardiogenic pulmonary edema, which is caused by increased hydrostatic pressure, versus non-cardiogenic pulmonary edema, which is caused by increased permeability of the alveolar capillary membrane. So cardiogenic pulmonary edema, we can get that with CHF, fluid overload, renal failure. So this results in increased pulmonary venous pressure, increased hydrostatic pressure, allowing the fluid to leak out into the air spaces. Now you do have to know these numbers. So the correlation between the chest radiographic finding and the pulmonary venous wedge pressure. So the pulmonary venous wedge pressure less than 12 is normal, 12 to 19 gives you sepalization, 20 to 25 gives you interstitial edema, and greater than 25 gives you alveolar edema. So normally, the vessels in the lower lungs are somewhat more prominent than the vessels within the upper lungs. That's just because of and this should be judged on an upright chest radiograph because of that gravitational gradient. When we start to get prominence of the upper lobe vessels, especially the pulmonary veins here within the upper lobes, then that's a sign of grade 1 pulmonary venous hypertension or vascular redistribution. You can also have widening of the vascular pedicle towards the right from distension of the superior vena cava. So distension of the superior vena cava can give you an idea of the intravascular fluid volume, and that's very helpful if you're comparing serial radiographs on the same patient. So this is the same patient here when they have some pulmonary venous hypertension, and here where they're more normal. Notice the widening of the vascular pedicle to the right here because of increased intravascular fluid. And also you have this structure here, which is a little bit more dilated than it was on the prior chest radiograph. What is the structure?
Azygous vein.
Right, the azygous vein. So you can have distension of the azygous vein also. So this helps when you're looking at serial chest radiographs when you're trying to assess the fluid status of a particular patient. With grade 2 pulmonary venous hypertension, we get interstitial edema, and there we get curly lines. You can also have some pericardial cupping, thickened fissures. What are curly B lines?
Transverse thickened pulmonary septa,
Where do they occur?
bases, and periphery.
In the periphery. Curly A lines, all of these are thickened interlobular septae. All curly lines are from thickened interlobular septae. Curly A lines are? They radiate out from the hyla, and curly C lines, they're overlapping of curly A lines and curly B lines. So curly B lines occur in the periphery, curly A lines radiate out from the hyla, and curly C lines, we have overlapping here of curly A lines and curly B lines. So with these curly B lines, they're the ones that are easiest to recognize. Here on the close-up, you can see these lines in the periphery at right angles to the pleural surface. So this is very helpful if you're looking at a chest radiograph in somebody's emergency room, short of breath, and you notice curly B lines, then you can suggest interstitial edema as the problem for that particular patient. So all of these represent thickened interlobular septae. So this is a CT in somebody with central lobular emphysema and interstitial edema. So it shows you these thickened lobular septae very nicely. So these outline the secondary pulmonary lobules, and these in the periphery are what give us the curly B line. So don't mistake interstitial edema for lymphangitic carcinomatosis. Right, interstitial edema gives you smooth interlobular septal thickening. Typically, lymphangitic carcinomatosis will give you nodular interlobular septal thickening. So the most common cause of smooth interlobular septal thickening is interstitial edema. And on CT, we often do CTs for pulmonary embolism, for patients short of breath in the ER, and they turn out to have interstitial edema. So you do want to recognize that on your CT scans. So if you notice the thickened interlobular septae, and for whatever reason, sometimes they're easier to see in the upper lobe than the CT scan, then we can say that the patient has interstitial edema. Now, when we get to grade 3 pulmonary venous hypertension, then the fluid goes out into the alveolar airspaces and we get consolidations. You may have this typical bat wing or butterfly distribution of consolidations. And with pulmonary edema, these consolidations can change rapidly, and the distribution may also be dependent on patient position. So if the patient is lying right side down, maybe sometimes the consolidations will be greater on the right side. Helps if you have pleural effusions and cardiomegaly, of course, that goes along with CHF. So here's a 44-year-old woman presents to the emergency room with acute onset of shortness of breath, and the chest radiograph shows bilateral alveolar, we have airspace disease, and of course they will go to CT for pulmonary embolism, right? Everybody gets that in our ER when you show up short of breath. And the CT scan shows, what do we have on the CT? Hemorrhage. Who said hemorrhage? You said hemorrhage.
Yeah.
Why?
It's like hyperdense.
This is not hyperdense. This is normal enhancement of the lung parenchyma. So, Moret, you said you have
Left lower lobe consolidation,
Yeah,
bilateral right.
you have bilateral, you have this left lower lobe consolidation. This opacity here represents what? You would describe this as ground glass, right? Patient also has
Fusion.
pleural effusion. So what do you think is the cause of this? You think it's pulmonary hemorrhage?
No.
No, okay. So what do you think is causing it? So you like pulmonary edema, so if you're thinking pulmonary edema, what else are you going to look at on the CT? You're going to look at the what? You're going to look at the heart. What do you notice about the heart?
It's enlarged.
What part is enlarged?
Left atrium.
Left atrium and left ventricle, right. So, you notice anything else about the heart that might explain why this patient has pulmonary edema?
Subendocardial fat.
What?
The subendocardial hypotension fat.
Well, there's a little bit of, it's pretty subtle. There's some subendocardial region here that's somewhat lower in attenuation, so I'll show you a short axis, right? So here we have the subendocardial region that, remember, this is a CT scan for PE. This is not a cardiac CT, right? This is a, what kind of view is this? Well, how many chambers do you see? Two, so it would be a nice work. Good, that's a two-chamber. These are short axis views, right? These also nicely demonstrate this area of low attenuation in the subendocardial region. So patient in pulmonary edema, you see this, what do you think is going on? So we call that in medicine a myocardial infarction, right? Okay, and so the patient goes to the cath lab, and the cardiac enzymes were positive, of course, and this patient was having an acute MI because of obstruction here. It was a obtuse margin bridge right over there in the cath. Okay. All right, the most common cause of cardiogenic pulmonary edema with normal heart size. Right, that's myocardial infarction. Usually we think of cardiogenic pulmonary edema as giving you a big heart, but you can have normal heart size if the patient has an MI and is in cardiogenic pulmonary edema. Less common, but an acute cardiac arrhythmia can also lead to cardiogenic pulmonary edema with normal heart size. Okay, so this pattern on CT is called?
Crazy paving.
What?
Crazy paving.
Why is it crazy paving? What makes it crazy paving?
Interlobular septal thickening superimposed on ground glass opacity.
Well, you get that with what you just described. You get on with pulmonary edema, right? Pulmonary edema gives you interlobular septal thickening superimposed on ground glass opacity. Why do you call this crazy paving? What makes this crazy paving and not just ground glass with interlobular septal thickening? You said crazy paving, right? What was it that made you look at that and go, wow, that's crazy?
No, I just had to look.
Just had to look. So what is it about the look that makes it crazy paving?
That's what the mosaic
Mosaic.
What?
The mosaic perfusion.
Well, it's not really mosaic perfusion, no. I mean, there is mosaic attenuation, right? You have areas of decrease and increased attenuation here.
The ground glass opacities are like denser.
You're just into dense ground glass. You're just going to use that for the whole
That's what I
conference,
think
aren't you?
of with crazy
Yeah,
paving.
you're going to go with pulmonary hemorrhage on this too?
We can.
Let's not. That comes later in the course. Okay. Look, first of all, you're right in the sense that crazy paving can be associated with pulmonary hemorrhage. Okay, but the most common cause of crazy paving, if you see it in clinical practice, is what? What'd you say? Come on, spit it out. Not
Well,
the
I was
pizza,
thinking
but
about pulmonary.
yeah, you're thinking about pulmonary alveolar prognosis. Of course, that in the textbooks is associated with crazy paving, right? So certainly you should have that association in your mind. But is that the most common cause of crazy paving? If you see it in clinical practice, it's going to be what?
Pulmonary edema.
It's just going to be plain old pulmonary edema. Now, what makes this crazy paving is that, yes, you do have ground glass opacity with interlobular septal thickening, but when you look inside the pulmonary lobules, you also notice what? See the reticularity inside the secondary pulmonary lobule, yes or no? Come on, humor me. Yeah, of course, we all see it. So what do we call that? Well, if this is interlobular septal thickening, this is intralobular septal thickening, right? That's what makes it crazy paving. So what makes it crazy paving is that you have these geographic areas of ground glass opacity. There are areas of the lung that are spared, and then you have these areas of ground glass associated with interlobular and intralobular septal thickening. So it's that intralobular septal thickening that really makes this look a little bit different than those other cases of plain old ground glass opacity that you see. And that's what makes it crazy paving, okay? But as we've said, when you see crazy paving in clinical practice, it's probably most likely to be pulmonary edema. Now, what are some other things that might give you crazy paving?
COVID-19.
What? Yeah. So certainly pneumonias, right? Especially viral pneumonia can give you crazy paving. What other kind of pneumonia is associated with crazy paving? Now, we do see quite a bit of here in Newark. Ground glass, pneumonia,
PJP.
what?
PJP.
Yeah, pneumocystis pneumonia, right. So that can also give you crazy paving. So this was a case of pulmonary edema. It's giving us crazy paving, okay? Now, there can be drugs that can also give you an appearance like this, okay? A drug can do that. Well, what do we think's going on in the patient? What do we think this is? We have bilateral diffuse ground glass opacity, right? It has a very broad, long differential diagnosis. The first thing you might start with is, what's the first thing? The differential for diffuse ground glass opacity.
Pulmonary edema.
Pulmonary edema, good, right, sticking with the topic of the lecture, nice work. So what drug might give you pulmonary edema?
Opiates.
Yeah, absolutely. Here in Newark, we see quite a bit of this, right? So opiate overdose can put patients into pulmonary edema. That was the case here. So that is, if you have a young person who looks like they're in pulmonary edema, that is something else to also consider, right? Another interesting appearance we can get is what's called this intralobular gradient. If the patient's lying on their back, because of the gravitational dependence, actually inside the secondary pulmonary lobule. You can see that it's somewhat denser in the dependent portions of these secondary pulmonary lobules. So it's a very interesting appearance that you might also get with pulmonary edema. Now, non-cardiogenic pulmonary edema, we can get this with many causes. The very common cause is ARDS, but then there are all kinds of other things that can also give us non-cardiogenic pulmonary edema. I mean, the list is endless for this. But ARDS is something that we do need to be familiar with. So this occurs from alveolar capillary injury, results in leakage of edema fluid into the alveoli. The edema is prolonged because it's the proteinaceous content of the fluid gives you high oncotic pressure, so the resorption, you don't have the normal forces, oncotic forces for resorption, and it requires high concentrations of oxygen and high ventilatory pressures to overcome the decreased lung compliance, which can lead to all kinds of complications, one of which is illustrated here. Barotrauma, which results in
Subcutaneous emphysema.
yeah, extensive air leak here, subcutaneous emphysema. Right? We also have pneumomediastinum, pneumothorax, all of that associated with the barotrauma. So there are many causes of ARDS. I'm sure all of you are familiar with these, but trauma, shock, severe infections, some of the more common causes of ARDS. Now, the histologic pattern associated with that is diffuse alveolar damage. So that goes through various phases. There's an acute exudative phase where you get hyaline membranes and protein-rich edema, and all these necrotic epithelial cells fill the alveolar air spaces. That's called the exudative phase. And then gradually it goes through these other phases too. There's a proliferative phase with proliferation of type 2 pneumocytes, and then a chronic fibrotic phase where the patient develops fibrosis. There is a difference between the etiology of the fibrosis associated with ARDS or diffuse alveolar damage versus UIP. With UIP, the fibroblast proliferated in interstitial. So these patients get interstitial pulmonary fibrosis. With ARDS or diffuse alveolar damage, what happens is all of that stuff that is spilled out into the alveolar air spaces becomes organized and then becomes attached to the alveolar wall as the fibroblasts go through the fibrotic process. So that's called fibrosis by accretion, as opposed to fibrosis primarily within the interstitial. So when we get to the fibrotic phase, you can see that organization here that affects the air spaces, and you can see how this would affect the oxygen exchange in these patients when they develop fibrosis after ARDS. And then these different phases, even though we talk about them, there is an overlap between these phases. It's not a very clear-cut transition from one phase to the other, so it is kind of overlapping in terms of how they progress from one phase to the other. Differences or things that you need to note about ARDS is that the findings on the chest radiograph can be delayed up to 12 hours after the onset of symptoms. So the patient may crash, they get a chest x-ray, the chest x-ray looks relatively normal, and it's a few hours later that you see the developing consolidations, the bilateral consolidations from the ARDS. So it's usually bilateral. The consolidations persist for days to weeks, day after day after day. We're reading these chest x-rays on intubated patients in the ICU, no change, no change, no change, bilateral consolidation. That's what you see with ARDS. And then it may go on to develop fibrosis. Another appearance to recognize is this gravitational gradient, because what happens is the lungs are very stiff, and so what we're looking at mostly is atelectasis when the patient is on their back. So you will see this gravitational gradient of the opacity on CT scan. So that's very typical of ARDS, where it's denser towards the dependent portions of the lung than elsewhere. And then these patients, they can also they also treat them by rotating and turn them to even out the oxygen exchange throughout the lungs and to minimize lung injury. And so here, this patient was prone after 12 hours, and you can see that from being prone, there's still that gravitational gradient, only now it's more anterior because of the patient's position. Okay? Whereas here, it was mostly posterior because of the patient's position. So we can have ground glass opacities, diffuse ground glass opacities. We can see that with ARDS. Now, when we get fibrosis with ARDS, we start to see traction bronchiectasis. So you see that traction bronchiectasis during the fibrotic phase of ARDS. The difference between the fibrosis we see with ARDS versus UIP, what's different? Any ideas? Well, what's typical of fibrosis with UIP? We see what?
Honeycombing.
Honeycombing in the peripheral distribution. Do we see honeycombing with ARDS? No, we don't. Right. So fibrosis from ARDS does not give you honeycombing as opposed to the fibrosis that is typical of IPF or UIP. Many complications of ARDS can be related to barotrauma. Another one illustrated here. What's the complication? You're reading this chest x-ray, you're going to stare at it blankly like this for pneumomediastinum. Yes, right. We want to recognize that, right? When we're reading a chest x-ray, you want to be able to recognize pneumomediastinum right away. So barotrauma, very common complication from ARDS. Not so much in adults, more likely in children, is interstitial emphysema, where the air actually from the barotrauma dissects along the interstitium and gives you these curvilinear, lucent areas of air, actually dissecting along the interstitium. And then, of course, pneumatoceles, which can also occur as a complication from barotrauma with ARDS, especially also in the thorax. After recovery, can be left with fibrosis, usually traction bronchiectasis, but again, we don't see honeycomb from ARDS. Another interesting appearance about the fibrosis associated with ARDS is it tends to be anterior predominant, or it may be anterior predominant. So this is thought to be related to oxygen toxicity, because with the patient mostly lying on their back, the higher oxygen concentrations go to the more aerated regions of the lungs, which are anterior. And so that results in lung damage from oxygen toxicity. And so the atelectasis actually protects those regions of the lungs from the fibrosis and oxygen toxicity to kind of even out the damage in the lung. That's why rotating these patients might be helpful. So this anterior predominance of fibrosis can also be characteristic of the ARDS. So here you can see the dependent consolidations we see with ARDS, and then When this patient goes into the more fibrotic phase, you can see that fibrosis is somewhat more anterior predominant in this particular patient with ARDS. Here's another example of that. So you can see these reticular opacities, and then the predominance here in the anterior portions of the lung as the fibrosis, the fibrotic phase of ARDS, somewhat worse in the anterior portions. This sagittal reconstruction also shows you this traction bronchiectasis very nicely in the anterior portions of the lung. What kind of recon is this?
Minimum.
That's a minute, right. So if you're looking for airways, if you're looking for loosen areas, then we like to do minutes that shows those areas better as opposed to what we use for as opposed to MIPS, which is what you use when you're doing vascular. Okay. A few definitions. Diffuse alveolar damage, that's a histologic pattern of injury. Acute lung injury is a clinical syndrome associated with diffuse alveolar damage. On pathology, there's a definition here as far as the PaO2 and the FiO2 gradient, as opposed to ARDS, which is a clinical syndrome associated with acute symptoms, diffuse pulmonary opacities, exclusion of pulmonary edema, and then the ratio here of the PaO2 to FiO2 is much lower. And then AIP, acute interstitial pneumonitis, idiopathic interstitial pneumonia, which essentially is idiopathic diffuse alveolar damage. So we don't know what caused the alveolar damage in most patients, but it is one of the acute interstitial, it is one of the idiopathic interstitial pneumonia. Differentiating ARDS from pulmonary edema can be difficult. With pulmonary edema, the infiltrates coincide with symptoms, can be perihilar, whereas here it's all lung zones. We've talked about consolidations being delayed, peribronchial cupping less common, septal lines usually not present, air bronchograms less common with ARDS. It's said that with ARDS, the fluid also extends into the airways, so that we don't get the air bronchograms with ARDS as commonly as we do with cardiogenic edema. Infiltrates can change rapidly here. Here they change slowly. Wide vascular pedicle, signs of increased intravascular volume not present with ARDS. And pleural effusions, very typical of cardiogenic edema, not so much with ARDS. And then, of course, many other causes of non-cardiogenic pulmonary edema. We know from toxic inhalation, also as the chemicals act as irritants to the tracheobronchial tree. What causes Silofiller's disease?
Just inhalation.
Yeah, it's organic
What?
dust inhalation.
Organic?
I think it's
Okay,
nitrate.
wonderful. You stepped into the trap. So, inhalation of organic antigen that results in lung disease is called hypersensitivity pneumonitis. All right. So, hypersensitivity pneumonitis. What do we call that when we're talking about farmers? We call that
Farmer's lung.
farmer's lung, right? And that's caused by
The
moldy hay and actinomycetes within the moldy hay, right? So that's different. So here we're talking about something inorganic, right? So for Silofiller's disease, that inorganic product is
The nitrates.
nitrogen dioxide. All right, so that forms within the silo. It can be inhaled. When it's inhaled in the lungs, it converts to nitric acid, and that causes the lung damage associated with Silofiller's disease. It is a common test question, actually, to try to confuse you between Silofiller's disease and farmer's lung. Okay, so you have to make that distinction. And the long-term complication of this would be
Fibrosis?
who?
fibrosis.
No,
Fibrosis?
fibrosis of what?
Of the lungs?
No.
No.
Well, what part of the lungs? The small airways, and we call that bronchiolitis obliterans. Bronchiolitis obliterans is the long-term complication. And that can give you these areas of bronchiectasis and then these areas of air trapping. Okay. So that's bronchiolitis obliterans. Smoke inhalation, acutely after smoke inhalation, the patient may be asymptomatic with a normal chest radiograph. So how do you know the patient's at risk for smoke inhalation? And because 24 to 48 hours later, the patient can crash. How do you know if this patient's at risk for smoke inhalation? We've got to keep the patient, observe the patient. What? So they look for soot, right? around that. What else? Well, patient was extricated from a burning building. Can't hear you.
CO2?
Not CO2, but carbon monoxide,
Yeah,
right.
yeah.
Elevated levels of carbon monoxide can be an indication that the patient is at risk for smoke inhalation. Okay? Opiates, we've talked about this, is also can result in non-cardiogenic pulmonary edema. Cytokines, these chemotherapies, 25% with interleukin-2 can develop pulmonary edema as a complication of some of these chemotherapeutic agents. Near drowning, that can also be a cause of it. So initially, the consolidations we see can actually be the fluid that was aspirated. But then when that clears up, they can also have damage to the lungs as a result of what they've aspirated that can also prolong pulmonary edema in these patients, non-cardiogenic pulmonary edema. How do we put these two images together? What's going on in this patient? Well, the finding on the first image is, okay,
Could it be neurogenic?
yeah, so, and neurogenic pulmonary edema is associated with, why do we call it neurogenic pulmonary edema? It's associated with what?
Injury to the spinal cord?
Exactly, right, CNS injury to the central nervous system, right. So that's associated with neurogenic pulmonary edema. So it can be injury to the spinal cord or the brain. Severe injury to the brain can give you neurogenic pulmonary edema. So acute injury to the brain or spinal cord can result in intense sympathetic nerve discharge that results in hydrostatic edema. So neurogenic pulmonary. Okay. How do we put these together? Yeah, so fat embolism, injury to lung bones. So it's very, how often I get requests for PE scans to rule out fat embolism syndrome. Does that make sense? Why? What? Why? They have fat embolism. Why can't we see it on the CT scan? What's the pathophysiology of fat embolism syndrome? So after injury to long bones, the fat within the marrow gets released into the bloodstream, and then do they immediately crash after that, or does it happen sometime later? It happens later. Why? Because lipases within the blood converted to free fatty acids, and it's those free fatty acids that are actually damaging to the lung parenchyma, which is why the symptoms tend to occur a few days after the initial injury. And so what we see is a pattern of pulmonary edema or non-cardiogenic pulmonary edema consolidation. We don't see the fat embolism itself because these are microscopic. Okay, it's free fatty acids that are causing the damage. Right? So fat embolism syndrome after injury to long bones. A few days later, patients might crash going to pulmonary edema. So 72 hours later, after the injury, we see the pulmonary edema. So if you see consolidations on a chest radiograph like that in a trauma patient, go back and look. Do they have long bone fractures? Maybe it's a case of fat embolism syndrome. So that is something that you might be able to suggest. Okay? And we have a fluid embolism. This occurs late in pregnancy. So disruption of the uterine wall, rupture of placental membranes, and you get embolism of that material that can also result in pulmonary edema. Acute airway obstruction, prolonged hypoxia, even after hanging or attempted hanging, patients may have pulmonary edema. Laryngospasm can also do it. For whatever reason, it's said that this type of edema can spare the periphery of the lung, that the periphery of the lung can be spared when you get edema from this acute airway obstruction. The cortex can be spared. This patient's short of breath after arriving in Denver. Broncos lost a bad game.
Or maybe the altitude is a little high.
So we call that
Altitude sickness.
so high altitude pulmonary edema. So this can be another cause of pulmonary edema. Usually greater than 11,000 feet. Pulmonary edema occurs 3 hours to 3 days after ascending. The pathophysiology is not well worked out, but it's thought to be related to the hypoxia, heterogeneous vasoconstriction, results in pulmonary hypertension, also increased capillary permeability, results in 25-year-old man, cough, fever, chest pain for 1 week, negative, chest x-ray shows. Is that a normal chest x-ray?
Bilateral basal predominant.
Yeah, so you have bilateral basal predominant consolidations. What would you offer as possible causes?
Pulmonary edema.
The 25-year-old? I mean, if you're going to say pulmonary edema in a young patient, you know, what are some things you might say was causing it? We talked about opiate overdose, right? So that's certainly one
Yeah.
thing.
Vaping.
Certainly something we have to ask the question about. Viral pneumonia, right? That's something we have to bring up also nowadays. Aspiration, if you have basal predominant consolidations, right? That's something else that you also have to suggest. Okay? So on the CT, we have these consolidations here, somewhat peripheral in distribution, okay, with these consolidations. And the activity, of course, that you need to ask these people about, as you brought up, is
Does he
vaping, right? So the CDC criteria for this definition is not very satisfying. Use of vaping product within 90 days, pulmonary opacities and chest radiograph, no infection, no evidence of alternative plausible diagnosis. So it's a diagnosis pretty much of exclusion. There are various patterns that have been described with vaping-associated lung disease. It's thought that these products, vitamin E acetate, THC, are what's causing lung damage in these patients. But the various patterns, acute lung injury, where you get consolidations within the lungs, an organizing pneumonia pattern, peripheral consolidations, hypersensitivity pneumonitis pattern, more central lobular diffuse consolidations, acute eosinophilic pneumonia pattern, peripheral consolidations. The acute lung injury pattern is probably the most common that you might see, but the point is, young person with unexplained consolidations nowadays, you know, respiratory difficulty, we have to raise this possibility. So this is something to consider, vaping associated lung disease. So what do we have here? Normal or abnormal? Chest x-ray. So is the x-ray normal or abnormal? Let's start there.
Abnormal.
Thank you. What's wrong?
Be great.
To think that we're going to, in 20 minutes, we're sending all of you back down to the reading room. It's a frightening thought.
The pacification of left.
Maybe not in 20 minutes. Yeah, so we had, now what's striking is that the opacification is only affecting one side. Right? So, and also you notice the patient has a chest tube. Okay. So we can't put this together by saying the patient has.
And pneumothorax and re-expansion pulmonary edema.
Could be, yeah, so it could be re-expansion or reperfusion pulmonary edema from pneumothorax, or maybe more likely from
Hemothorax.
drainage of what?
Pleural effusion.
Pleural effusion, right, drainage of a large pleural effusion, right? That can also give you re-expansion pulmonary edema. So here we're in the category of unilateral pulmonary edema, right, where we have unilateral consolidation. And certainly, re-expansion is probably the first thing to think about, a reperfusion pulmonary edema. But there are other things, gravitational, if the patient likes to lie left side down, underlying lung disease, you can have an asymmetric pattern of pulmonary edema if you have an asymmetric distribution of COPD, contralateral to an obstructed pulmonary artery. So if this patient had a PE and then developed pulmonary edema, what side would the PE be on? It says contralateral to an obstructed pulmonary artery. Right, so the PE would be on the right side. Good. Ipsilateral to an obstructed pulmonary vein. What side would the obstructed pulmonary vein be on? Left side. Very good, yes. So those are other causes of asymmetric pulmonary edema. So large pleural effusion, put in a chest tube, the effusion is drained, the lung re-expands. the rush of perfusion to that lung, the lung is not able to handle it because when the lung was collapsed, the chronic hypoxia does result in some damage to the alveolar capillary system there. And so when you get that rush of perfusion, when the lung is re-expanded, you get leakage of fluid into the lung, and that is re-expansion or reperfusion of pulmonary edema. So a very nice example here, pleural effusion, chest tube, re-expansion, pulmonary edema, nicely demonstrated there on the CT scan also. That consolidation only on one side of the patient. So we've gone through the mechanism of that, so it can occur with a prolonged pneumothorax, chronicity of collapse, high negative aspiration pressures. All of these can be factors that increase the risk of re-expansion of pulmonary edema. You can also have unilateral pulmonary edema after what surgical procedure?
Lung transplant.
Yeah, so which lung was transplanted?
Here, the left lung was
The left
transplanted.
lung, right. And that is another form of reperfusion pulmonary edema. Because the lung transplant itself, the lung, of course, is hypoxic, the lung that they're going to put into the recipient. And so when they attach the vessels to the lung, the pulmonary artery to the lung, you get another form of reperfusion pulmonary edema. So that can be after a lung transplant. After what interventional procedure? What interventional procedure can give you unilateral pulmonary edema? What's that? Thoracentesis, well, that we kind of talked about for re-expansion, but I'm talking about something that's done, I mean, that doesn't have to be in the interventional suite, right? Thoracentesis.
Like a PE thrombectomy?
Yeah, PE thrombectomy. So if there's a clot, big clot that's obstructing the left pulmonary artery, if they go in there and do a thrombectomy, again, you're getting reperfusion pulmonary edema on that side. So that can also give you reperfusion pulmonary edema. Okay, so those are the causes of reperfusion pulmonary edema. This patient had end-stage renal disease, likes to lie right side down, so that results in the pulmonary edema on that side. Asymmetric pulmonary edema patients with COPD. The regions where you have the emphysema can be spared from the consolidation, so that can give you an asymmetric appearance of pulmonary edema. So here, because of the oli up here, you can see the pulmonary edema is kind of asymmetric in its distribution within a particular lung. Okay? So that is our discussion of pulmonary edema, and now we go on to